Thank you, Chairman. I'm Son from Busan National University again. No disclosure. I have just 10 minutes, but
Now it's going to be shorter.
Thank you.
We equal. We give you 8 minutes, and Professor Lee 8 minutes or so.
Yeah, shorter would be better.
When I was a young surgeon, I have some painful experience of this case. After Rowan-2 resection, after 9 days, this patient have some ischemic colitis in left side, and I need to perform the total colectomy again. And until now, this patient have some permanent ileostomy. It's my painful case, so I start to have some concern about the vascular structure. So first time I want to compare the high ligation and low ligation. So for the patient's safety, I just dissect the vascular structure around IMA, and I just have some clamping in IMA root, and I measure the marginal artery blood flow, blood pressure, and I can find just almost 10% of patients have some abrupt decreasing of the marginal artery pressure after IMA clamping. So 90% is okay. High ligation, low ligation is no problem, but 10% have some high risk of ischemic colitis after high ligation of IMA. So at that time, the near-infrared camera system is introduced in my hospital. So I want to emphasize some different light source. Some instrument use the xenon lamp, and some is use the LED, and some is use the laser. So it has some different spectrum. So and some different characteristic of the fluorescence image. So we must remember that we have several different light source. So ICG attached to albumin in intravascular area, so we can see the vascular structure and perfusion status. At first time, I analyzed the ICG image by using the Excel program and ImageJ program, and I draw this graph. Just one graph need 3 hours for analysis. It's very, very tough, the working. But I can see that just showing ICG is not enough, because this first case is very abrupt, increasing the fluorescence intensity is very good perfusion. Last case, the ICG was shown in vascular structure, but enhanced time is very long. It's very, very poor perfusion status. So we need to differentiate perfusion speed, perfusion status using this quantitative analysis. So I draw this graph using another program, and I analyze the time of perfusion and intensity level, and we try to develop the analyzing program. Nowadays, we need just 5 seconds for analyzing the perfusion status using this. It is very automatically analyzed. It's very easy. So in my case, I can find some complication case is just gathered in this area. This area have some time-delayed fluorescence image. So time ratio also delayed, and T-half max is also delayed. So this patient actually have some very high risk of the perfusion status. So we can make some analysis step like this, and we use the quantitative perfusion parameter. We can classify the dangerous group and safe group. So in my series, dangerous group, the patient has anastomotic complication to the 70%, very high risk. Actually, initiating period of this study, I don't know the safe level of ICG, so I just inject ICG, and when I see the ICG, I try to anastomosis, and after then, I must have some several cases of anastomostic complications. But right now, we can move transaction line change, and we can choose the good perfusion segment for anastomosis, and then we can we can prevent these dangerous patients to the safe period. So fluorescence image is affected by many other factors, environmental factors, ICG dose and distance from the camera to the colon, or room light, many things is affected by fluorescence intensity. So we need to standardize our protocol. So, and it's very interesting, the image. When you use the very high dose of ICG, for instance, is decreasing, or so this means a quenching effect. This is physics of the fluorescence material. So we need to dilute the optimal level of the ICG. So, and the intensity of the fluorescence is also very depending on the distance from the camera to distance. So we found some 5 centimeters from the specimen. It might be the optimal level, optimal distance for fluorescence image. So we need to standardize every detailed protocol, and we check the ICG, and we can compare the fluorescence intensity after using the standardized protocol. Is important in my opinion. So I want to show you some in the case. Actually, the SUDEC point is the disconnection of the marginal artery. So in this case, we preserve the left coronary artery and preserve the sigmoid artery, but the patient have some ischemic the segment. I believe this patient have some disconnection of the marginal artery. So initially, I tried to anastomosis in here, but this almost 10 centimeters of segment shows some poor broad perfusion. So I move to the proximal side, and I can choose the good perfusion area, and this patient have no anastomostic complications. So this graph pattern is show very slow increasing, but good point show the very fast increasing of fluorescence intensity.
You have 1 more minute. As like a debate.
Yeah. This is another case for right hemicolectomy. Actually, this patient have some SMA trunk anomaly. So terminal branch of the SMA and iliacoronary artery is combined and make some just single trunk. So when I ligate iliacoronary artery, the patient have some ischemic change of the small bowel, almost 60 centimeters from the IC valve. So proximal colon showed very good perfusion, but small bowel became ischemia. So I need to try again and again, try to find some good perfusion in here. So we anastomosis and patient recover very smoothly. So if I don't use the ICG, this patient choose this terminal ileum for anastomosis, and after the surgery, this long segment ischemic change makes some another serious complication like sepsis or rest. So I feel very comfortable during the surgery after using the ICG. So nowadays, at first time, I used the conventional dose of ICG, and under near-infrared camera system, everything is covered by the fluorescence, so I can't localize, I can't check some perfusion. It's terrible. So I want to perform the tumor localization and lymph node mapping and perfusion status analysis in one person. So I try to define the optimal level of ICG. So I de-escalate the ICG dose, and I found a very small dose, very small dose of ICG is acceptable for lymph node mapping and localization. So actually, I want to emphasize this new technology, like the ICG, could be very helpful for young surgeon, not for experienced surgeon like Professor Lee. He already performed more than several thousand cases of laparoscopic surgery, and he knows everything just using his naked eyes. But young surgeon, sometimes you have some equivocal condition for determine some transaction line or professional status using just your limited experience. So this technology is very helpful for young surgeons. So I have some study for educational benefit of ICG angiography for young surgeons. Actually, they're surgical resident and medical students. So just using this ICG image, their accuracy of determining the transaction line improved 2 times than conventional image. So I want to recommend this ICG for young surgeon, not for experienced surgeon. You never use the ICG. You can know everything. You know everything. Yes. And nowadays, I try to make some AI system using the perfusion status mapping like this. So AI system is very comfortable for classifying the very different pattern. So AI program can analyze each point of the of colon for analyzing the perfusion status, and AI's program can determine it's good, it's poor, it's intermediate, and they can express like the color map like this. It's very easy and very intuitive for determining the transaction line for a young surgeon. And future, I want to show you some future study. Actually, this is another imaging system, hyperspectral. And nowadays, with laser spectral image and hyperspectral image and ICG, we have many different advanced imaging technology. So nowadays, I study for the hyperspectral image and compare the ICG. So this patient has almost 7 centimeters ischemic change in here. Actually, this hyperspectra just use light. No, this system don't use the fluorescence material. Just use the image and analyze the spectrum and extract some the signal of the oxygenated hemoglobin, and they analyze the data and express the color map like this. It's very easy and just need 15 seconds for detecting and analyzing and expressing their data. So very fast, very easy. So I want to compare the ICG perfusion parameter and the spectrum, and I found some 30 seconds of the fluorescence enhancing time is very acceptable for good tissue oxygenation, so more than 60%. So this is our new project, and also we could imagine our the patient's mesenteric vascular structure using the ICG graph pattern. Like this, actually the A patient have some just normal vascular structure, so that shows us just a normal graph. So B patient have some very weak Griffith's point around the spinal fracture. So this patient has very slowly increasing the fluorescence intensity. Sorry, and C patient have some collateral circulation system. So this graph show double peaking like this, and this patient, when we perform low ligation, this showed another different graph pattern. So when we use this graph pattern, we can imaging the mesenteric vascular structure. This is our ongoing project. And this is another project. So this is a colon muscle layer. So colon micro circulation system have a very unique structure, like penetrating the muscle layer like this. So we can analyze the different phase of the enhanced pattern. So vascular enhanced pattern and some submucosal enhanced pattern could be differentiated using the AI program. So we try to make some novel perfusion parameter using this study. This is ongoing. So this is a summary. Actually, the Professor Lee will show you some clinical trial result. Until now, this is some equivocal. Some study show some positive rate, some study show the negative rate. Actually, the essential trial from the Japan got the improving the result of the ICG group, reducing the anatomic complication. But that's not superior. So, but I believe that study result is positive. So we need to wait for result of a well-designed, well-organized, prospective, multi-center trial in the future. Until now, it is under debate, but in the future, we can get some more advanced image technology and more specific, for instance, material, so we can get some new era for instance, imaging period for young surgeon in the near future. Thank you for your attention.
Thank you. Next, we have Professor Suk-Hwan Lee on the debate on the cons of ICG.
Okay, I really appreciate Son's presentation. So actually, I realized that the topic has been changed a little bit. It is just beyond my expectations. So actually, I am fully understand the value of ICG angiography. So I agree with Professor Son. Actually, as you can see, the study of the Professor Son during these 8 years, he had a lot of research about the ICG angiography. But I raised a question about the ICG lymphangiography. So I use the ICG whenever it is possible. So in my practice, ICG is not always possible because we have a limited number of the ICG available, the laparoscopic system. So I will not talk about the ICG angiography. So I will just talk about the ICG lymphangiography. So there are some advantages, and then actually the Gyung-Mo son already prepared some kind of the protective, defensive manner to overcome the negative result of recently published randomized clinical trial. So I will not talk about that. So I will talk about the lymph node things, about the ICG. And then actually this ICG, after the ICG and infrared fluorescent image technology introduced to recently, so I just thought all this but goodies. Actually, Gyung-Mo son already showed us some very old, 150-year-old, the concept about the lymphangiography. So it reminds me there is nothing new under the sun. So we know everything more than 100 years ago, but recently the new technology just reintroduced, and then we just got an interest about that, and then many report, sometimes, at first time, they showed only the good things, advantages. And then after that, when we try to reproduce that kind of data, they had some negative results. So we have to, we have to interpret the data very carefully. So actually, ICG lymphangiography was introduced recently. I just remember, so year 2002 in Yokohama, there is a meeting about the third International Sentinel Node Congress. So at that time, Sentinel Node mapping for the breast cancer started from United States, but it was very popularized to the whole world. So that's why we have a third International Sentinel Node Congress in Yokohama. So at that time, I was also interested in that, and I attended there. So I attended a dinner cruise during that time, and then recently I found the book, abstract book, over there. It was 2002. And then at that time, this was a very exceptional and very surprising figure during that time. This is a kind of the skip metastasis and extraordinary metastasis away from the original site, the origin of the colon cancer. So after that, most of the surgeons focus on trying to do some sentinel node mapping for the colorectal cancer. But after a couple of years ago, a couple of years later, actually that kind of the striking on expected skin metastasis did not occur very frequently. So the reported incidence of skin metastasis is as low as 5%, as high as 15%. So among those metastases, at that time, we also tried to find the micrometastasis over there. And then this micrometastasis will result in stage migration. So it resulted in the lower stage to upper stage, so stage migration to the late stage, and then this micrometastasis may controlled by our immune system, or their micrometastases are very effective with the chemotherapy. So the result is improving after we are dealing with the micrometastasis. And then after that, recently we also have another new technology like a ctDNA or liquid biopsy. So technologies are continuously evolving, but still, all these are goodies. So during that time, the isosulfan blue, lymphazoline, was very popular. But at the time, it was not available in Korea. So I asked the importer to import that kind of the material with my own expenses, with my research fund, whatever. So at that time, we had isosulfan blue, and then after that, to improve the detection of the sentinel node, some guys from the outside Korea, I believe, used the radioisotope. So it was the first time blue node, or not blue node, but later on, it's a hot node or a cold node, based on the radioisotope technique. So the name of the node changed a lot. And then first time, it was a ex vivo technique for the rectal cancer. Now, they moved the technique to the in vivo technique. And then the route of entry of the isosulfan blue is subserosal or submucosal. It is quite the same with the ICG right now. So this is a very old data, back to 2004. Unfortunately, preoperative CCRT makes the mapping failure very high. So for the rectal cancer patient, for the advanced rectal cancer patient, we usually give them the preoperative CCRT. So for the radiated rectal cancer patient, the value of lymphatic mapping has some questionable value, I think. And then there are some new technology, ICG, and then there is some report. So from Japan, I think, with 57 patients, lymphatic mapping was available in 75% of patients. However, higher failure rate of lymphatic flow identification in stage 3 or 4 patients. So we use this very important technique for usually patient population, not those population who need that. So the reason why we cannot detect the lymph node in a stage 3 or 4 patient, because the lymphatics are totally displaced by the cancer tissue, and then there is no perfusion over there. So ICG positive node does not mean the metastasis containing node. So that is another obstacle of ICG lymphangiography, I think. This is the result from the pooled analysis. So sensitivity is about 63%, negative predictive value is 81%, detection rate is 94%, and there is a possibility of upstaging in 15%. But as the Professor Son already mentioned, there is no standardized technique for the sentinel lymph node mapping procedure, and then we need some validation, and then there are some debate about the injection mode. Which is better, subserosal is better or submucosal is better? What is the exact time and exact dose of the ICG, and where to inject? There are so many problems, the questions to solve right now. So this is the same thing I mentioned already. By using the ICG lymphangiography, I think we usually do not change the surgical plane. So during the previous talk, not this debate talk, the last session's talk, Professor Son showed us lymphangiographic and lymphadenectomy based on the ICG injection. So I asked him, what is the stage of that patient? And he told me it was T2. So actually for the T2 cases, we do not have to do some T3 dissection over there. So the nodes with the ICG signal does not have any metastasis. So for the stage 2, he said 3% of the node metastasis rate. So if you are doing the central area node dissection based on the ICG technique, we will have 97% of unnecessary lymphadenectomy over there. And then that will result in some kind of the lymphocyte problem or sometimes chylic problem or post-operative diarrhea or something like that. So we can avoid some unnecessary lymphadenectomy by omitting, not doing just ICG lymphangiography in those patients. So right time correcting with DC dissection, by this study, we can retrieve more nodes, but those nodes are not always the metastasis-containing nodes. Though the number of metastatic lymph nodes was not significantly different between two groups. So we already corrected the unnecessary node by using this technique. For the lateral node, the number is same, very similar. So I'd like to conclude my talk like this. The near-infrared identification of lymph node outside standard lymphatic station occurred in 52%. Amongst the high volume is recommended to identify the lymph node higher volume, but the higher volume does not mean a higher concentration. So we need some more things about that. So based on the EAES consensus, the ICG it has some only research purpose only. So it is not recommended to the routine clinical practice yet. So ICG lymphangiography is feasible. By using ICG, we harvested more nodes, but high detection of sentinel node. But I think we might have some unnecessary operation based on this lymphatic Bayesian-oriented surgery. So for the future perspectives, with the improving technology, we have some radioisotope material tagging anti-CEA. So I still believe the new technology will just improve our care to our patient. Thank you very much.
Thank you very much. Can I invite Professor Lee to the front? We have limited time for questions, but this debate is very interesting. I don't know what my co-chair thinks, but I think there's both speakers have some interesting technique. Number one, they use evidence on the last few slides as a debate, and sometimes if you analyze the evidence, you can believe it or you cannot believe it. But I think Professor Lee has a very strong point because he used the evidence and he used guidelines to say that ICG lymphography should be in the research phenomenon rather than routine practice. So if you use that, his debating power is very strong. On the other hand, Professor Sun has very good research credential. It appears his whole life is that's why he said, since his patient having the ischemia, his life is dedicated to improve. And with ICG and even with the latest technology he showed, the HSI, it is very difficult to say no to the way that he wants to do it. But both speakers, I just summarized, agree that ICG perfusion study do we agree that this is something that should be a standard of care? Is it correct? Am I correct? And maybe because of this, I would like to ask the audience, who uses ICG routinely in their hospital for bowel perfusion?
Routinely.
Routinely meaning if you have it, you will use it. I mean, sometimes the theater is busy.
Yeah, sometimes.
So maybe only some. Not sure whether there's some reasons for not using it. Maybe I can ask those who are not using it. Yeah. Professor Lee, yeah.
Yeah, I think the usual practice is quite overused because usually I check the bowel color and the epiploic pulsation and even cut down the blood pressure is enough to check the bowel perfusions. So I sometimes use the ICG angiography.
Then checking the such kind of a thing is enough, do you think? So
Right.
marginal artery, the blood, I know that the Hassan already published that they divided the pulsation from the marginal artery grading ABC or something like that. That is more reliable. So they're cost effective, reliable. So we don't have to use the ICG for the blood perfusion.
Yes, and speedy.
Yeah.
Yeah, shorter the operation times.
Okay. Short operation time. Cost
The
effective.
shortened operation time, I don't agree, because I thought ICG is very fast in our practice. But it is true, ODs can be goodies. So I think the debate is still out there for perfusion study, because there will be people not wanting to use the system. I guess I didn't use it until my hospital had the system. And when I use it, even if it's 100 cases and there's one that changed my surgery, I consider it a benefit for the patient. Because I similarly always thought that right hemicolectomy, I wouldn't use it, because the right colon the small bowel is full of nice blood flow. I don't even want to check. But there's one time that I used it and checked, and I had some ischemia, maybe because of sometimes during the intracorporeal anastomosis, during the mobilization, there's too excessive traction, and that changed my surgery, just like what Professor Meena showed on that area. But I believe what she showed is correct. We have to, if we want to use it, we have to believe it, or if we don't believe it, we have to redo the test again, because I think the ICG especially is good if you're doing everything intracorporeal. Extracorporeal, you can feel and you can see the blood better. Intracorporeal, there is sometimes a lack of the senses, and that is probably one benefit of ICG as we move towards more laparoscopic, totally intracorporeal surgery, whether it's right surgery or left hemicolectomy or anterior resection. Yeah.
One thing that I'd like to comment is the modern anatomy that denies the existence of Sudex point or Griffith's point, because the marginal arteries, all the marginal arteries are connected. It is already exist, but when we think about Sudex point and Griffith's point, it is far away from the marginal artery. We can misunderstand it didn't exist the marginal arteries, because the marginal arteries always exist. However, the spline flexure or the sigmoid make omega loop is long away from the marginal artery. It is sometimes we misunderstand. There's the disconnecting point of the marginal arteries between them. So I think the value of the ICG is to confirm that we can show the existence of the blood supply to the bowels. Yesterday we discussed that. Today morning. So these kind of navigations. So the experience, the driver can drive without the navigation. However, if it exists, we can get a help. From these days, there are 30 kilometers. The areas always exist. We can learn by the ICGs or something like that. Okay.
Okay, so to conclude, both Professor Lee and Professor Sun are winners, and the winners have to drink more during the welcome dinner. So thank you.
Okay.